Jean Chen from the University of Toronto, and I'm joined by my co-chair, Dr. Yi-Ru Lee from the Academia Sinica Institute of Statistical Science from Taiwan. The first speaker will be Scott Ensel, and he'll be speaking about lumbar spine fMRI to quantify efficacy of spinal cord stimulation therapy in spinal muscular atrophy.
Okay. Hi, everybody. Pleasure to be here. So today I'm going to talk about our spinal cord stimulation study in spinal muscular atrophy, where we use lumbar spine fMRI to quantify the results. So I'm going to start talking off about spinal muscular atrophy, but I'll call it SMA. That's not the supplemental motor area for most of you. So the idea with SMA is it's a neurodegenerative disease that affects the motor neurons in the spinal cord. Essentially, there's a reduction of the 1A synaptic inputs from the 1A afferents into the motor neurons. This causes a maladaptive property where the motor neuron refractory period extends, and it decreases the firing rate of these motor neurons, which displays itself in low strength in the muscles. So phenotypically, what this looks like in some of the participants, in our type 3 participants, is it affects the lower limb. So this is a more mild case of SMA, and you see from this position, this participant isn't able to stand up from a single knee, which most of you would be able to do. In a more severe case, in our participant that's degenerated a little bit more, you can see his gait pattern as he's walking during one of the clinical 6-minute walk tests that we perform. So the idea here is that in the last couple of years, there's been a promising therapy coming out called spinal cord stimulation. On the graphic here, you can see it's a kind of a simple implant where you put a stimulator into the epidural space of the spinal cord, and you're able to stimulate it. Now, this has been done for a couple of different diseases and disorders, and it's shown amazing results. And it's been done for spinal cord injury, it's been done for Parkinson's disease, and it's also been done for our group in the cervical cord for stroke rehabilitation. So the idea here is we want to use spinal cord stimulation for SMA. And the idea here about why it would work is that spinal cord stimulation will artificially increase the inputs of those 1A afferents into the motor neurons, causing an immediate increase in the firing rate, but also hopefully reversing these maladaptive properties that we see of here. So we designed a pilot clinical trial here where we implant these leads into 3 different participants, and we have a surgery, we do 4 weeks of strength and walking testing, and then we explant them. But not only did we want to see clinical improvements, we also wanted to see if we saw any changes in the motor neurons themselves. So we do 2 fMRI scans, 2 separate fMRI day scans before the implant, and then after we explant them. And so the idea here is that we're going to use this spinal cord fMRI to capture these long-term changes that we're predicting to see in the motor neuron function. So first, I'm going to describe about some of the clinical changes that we witness. So here are some plots of raw force traces that we measured during maximum voluntary contractions of their hip flexion, because they're more affected in the distal muscles and less in the proximal muscles. So you can see in the light purple, that's a force trace of their pre-study force that they were able to produce. But in the dark purple, that is the post-study force trace that they were able to produce. So you can see that in the first participant, they had almost 100% increase in the force that they were able to produce. And we also saw this kind of similar idea in knee flexion, knee extension, and hip extension, and the other different muscles that were affected by their joints. Now, the other thing that I want to talk about is that these plots were created when the stimulation was off. So this is just pure long-term increases in their muscular force. Not only that, when we do the clinical test of the 6-minute walk test, and we compare the performance and the gain of the distance that they were able to walk in this time compared to a control group of the same participants who did 3 months of strength and exercise training, we significantly outperformed them in the ability to gain. Now, one thing I want to kind of mention is that there's been multiple studies done on these types of participants, and it's been known that just strength training and rehabilitation doesn't help them fight these deficits they have. So you can kind of see immediately, what I'm going to show you again is those same kind of videos, but this one's an immediate effect of the stimulation on. And you can see that the participant is now able to get up from that position. And then this is a long-term change, and this is stimulation off of how much faster this other participant is able to walk now. So the idea here, right, is that I said that we would reverse these maladaptive changes, and this long-term reversion that we could measure with spinal cord fMRI, because the idea is if there's a faster firing rate, this would change the bold response that we see in an fMRI. So we designed a task-based fMRI where we were measuring the lumbar spine during an active knee mobilization task, where they did active extension and flexion of their knee over multiple runs over different days pre and post-study. Now, just to analyze it, I did a simple GLM where I regress out some of the physio measures, and we now can get an activity map of the active versus the rest periods. So kind of let's look at what these results look like. So on the left, you can see a T2 of one of the participants themselves, where I map out the different spinal segments that innervate the different muscles. So if you look at the L2, kind of that's an area that focuses, and that's the area that innervates the quadricep muscles, which is what's targeted during this task. You can see on the right side, in the top, that's the from one of the pre-scans, and in the bottom, that's the activation map from post in one of the post scans. And so you can see that there's an increase in the size of activation, but also the intensity of the activation in the Z-scores that we were able to get. So you not only see this in the first participant, but we also see this same phenomenon in the second participant and in the third participant, where they're all increasing. So this is nice qualitatively to look at, but I can quantitatively break this down into a histogram. So in the light purple, we see a histogram of the pre-study voxels, and in the dark purple, you see the post-study voxels. And you can appreciate that there's a massive increase in the number of voxels that were active, and also an increase in the Z-score. Now, I did some bootstrapping statistics here, and when you compare the means pre and post, you can see that there's a significant increase in these Z-scores. Not only that, but I can break this down into the ventral and dorsal side of the spinal cord, because in the ventral side, that's where the motor neurons are, and in the dorsal side, that's where the sensory neurons are. So you can see that this change that we see is stemming from a change in the motor neuron side, and these active voxels are being increased from a change in the function of the motor neurons themselves. So that's great. So we hypothesized more motor neurons are firing faster, but this data doesn't really exactly tell us what's happening, so it could be more motor neurons are firing and not just that they're firing faster. So during that clinical trial, we also did some high-density EMG analysis, where you put a high-density grid of electrodes on the quadricep muscles or the hamstring muscles. You can do this during maximum voluntary contractions, and you can look at the EMG signals, and you can do a decomposition algorithm to extract out single motor units and kind of look at how they're firing and how many of these motor units were firing. So specifically what we can look at here, on the left side you can see some pre-study traces, on the right side you can see some post-study traces, and these are traces of single motor units and how fast they were firing during an activity. Now on the right side you'll notice that we have labeled some rescued units, and so these were units that we found when we created a distribution of all the firing rates. They were significantly higher, 99% out of the distribution of all the other motor neurons and their firing rate. And so you can see in the bottom, there's also a raster plot of how fast these motor neurons were firing comparatively. So when we kind of analyze and look at all these rescued units for all the participants, we can see a significant increase in their firing rate compared to these still dysfunctional motor units. And in the bottom, you can see a pie graph representing what percentage of the motor units that we found were rescued by the end of the study. So to look at all of it, what we can understand is that spinal cord stimulation was having a direct effect on the motor neurons' recovery and was reversing these maladaptive changes. One, because we were measuring a significant increase in the bold response and measuring this neural activity directly inside of the spinal cord. And two, SCS promoted this reversal of motor neuron dysfunction in at least some of the motor neurons, and we saw this in a faster firing rate. Thank you. If you have any questions, you can contact me. And then this is also a QR code of the meta archive of the study that we have, if you want to check it out.
Thank you. There are currently no questions online, so I have a question for you. Can you comment on the neurovascular coupling mechanism in the spinal cord?
Yeah, so there's been multiple papers coming out in the recent years in the cervical spine showing that the neurovascular coupling, it is reasonable to measure bold activity in the spinal cord. There's been different tasks gripping left and right side where they showed laterality in the bold response. There's also been rostral-caudal distribution of different activations showing these responses too in different spinal segments of the cervical cord.
Okay, thank you. We have one more question. So since there are considerable anatomical variability in the human prefrontal cortex, especially at 7 Tesla, did you adapt your regions of interest?
I didn't perform any exact region of interest calculation on this. I took more of the spinal cord areas of the whole, and I was able to, I had a high resolution T2 image, so I was able to segment their spinal segments themselves, and then that's how I was able to kind of pinpoint and analyze different locations themselves.
Okay, let's thank the speaker once more.